referencing back to our historical case, our patient that has seen 3 lines of platinum-based chemotherapy and has now recurred again and is still considered appropriate for retreatment of platinum. So the standard of care, probably until 3 weeks ago, would still be a definitive answer of carboplatin-based therapy. And that would be appropriate. You could select single agent carboplatin because she's seen doublet therapy 3 times and she may be a little tired. So single agent carboplatin may be appropriate. She's not yet seen carboplatin and pegylated liposomal doxorubicin. So if she's of a constitution that you feel like doublet therapy could be useful, then that would be an option. And this is a patient who we know now does not have a germline BRCA mutation, so it would be important to test her tumor. So we don't have that piece of information yet, and that may also help us in this line of therapy, because if, say, we sent her tumor off for genomic testing and she was found to have either a germline BRCA mutation or perhaps was positive for the homologous recombination deficiency assay, then you might pick carboplatin or carboplatin and pegylated liposomal doxorubicin, try and get her into response again, and then use PARP maintenance. The PARP maintenance indication is not just for frontline or for first recurrence. It can be any line of therapy. And in fact, all of the studies that have looked at the use of PARP maintenance in the recurrent setting allowed for several lines of therapy. And so safety data does exist there. So those would be very reasonable therapies for her. The shift in the standard of care potentially came with SOLO3. And so SOLO3 was presented at ASCO in 2019. We're waiting for the manuscript and has not resulted in a change in the label, but it was the first randomized study to evaluate PARP inhibitor alone versus chemotherapy. So instead of chemotherapy, so instead of doing induction carboplatin or induction carboplatin pegylated liposomal doxorubicin and then trying to hope to get to a PARP, this goes straight to PARP versus chemo. Now I will say, and this was only in a platinum sensitive population, and they all had to have a BRCA mutation, but the control arm did not contain platinum. So that is one thing to know. But when you look at the response rate here, and there were patients who had to have been in 3rd line or beyond, the response rate was 80% for a PARP inhibitor in that line of therapy, in that late line of therapy, again, in a biomarker-directed population. But that's a pretty remarkable response rate in 4th line and beyond with very durable, it was a very durable response. And the progression-free survival difference also supported that overall response rate endpoint as a marker of benefit in that patient population. Now we've had an indication, in fact, the first indication for olaparib was in BRCA-associated tumors that had received at least 3 lines of chemotherapy based on a basket trial led by Bella Kaufman, which showed a 33% response rate in that population. And so this is the confirmatory study for that. And so that has been an accelerated approval for a long time. So it may not change so much the label, but I think it does add to the dialogue about, do you need chemotherapy at all in this recurrent setting, or can you go straight to a PARP? So we have the Bella Kaufman paper I just referenced that led to an indication. You have Ahmet Oz's work with rucaparib from study 10 and Ariel 2, which led to the accelerated approval for rucaparib in patients with 2 or more lines of therapy and a response rate that exceeded 50%. But that was a single-arm study. But that's, so those indications have been there, but only for patients with BRCA-associated tumors, and in the case of rucaparib, it could be somatic as well. So I think there's been some comfort with substituting in that biomarker-directed population. Whether or not we really completely are able to use PARP inhibitors beyond that particular biomarker population into HRD, into all-comers, platinum-sensitive, those studies are coming. So for this patient, without a BRCA-associated cancer, that would not be an indication right now, and so probably her best lines of therapy would be platinum-based therapy and hope to get her to a PARP maintenance, but very soon that story may change. If she did have a somatic BRCA mutation, a consideration could be to use either olaparib or rucaparib as instead of chemotherapy, and that would be on label as well. but you would need her molecular profiling to know that.